I'm Dr. Robert Berry, and I'm the Medical Director of Orthopedic Sports Medicine at Sports Physicians, Orthopedics, and Rehabilitation of Texas. And today we're going to talk about ACL reconstruction and what's new. Specifically, we're going to cover graft options and things that you likely have heard about or read about, allografts, which are grafts taken from others, or autografts, grafts taken from oneself. We're going to talk about artificial grafts and the future of those, as well as the different approaches for making tunnels in order to reconstruct an ACL. And so one of the questions that comes about when we talk about anterior cruciate ligament reconstruction, is there an ideal graft? Well, like some people may say, if you ask the ladies, they're waiting for the perfect man. A perfect graft may not exist, but the perfect graft would look like this. It would have no harvest or graft site morbidity. That means that we wouldn't do more damage to one's body by taking the graft. It would have high initial strength so we could perform rapid rehabilitation, and it would have no tunnel mismatch. That means that if we take your graft from your knee, for instance, your middle of your kneecap tendon, it wouldn't necessarily hang out the end of what we call graft tunnel mismatch. And so this is something that sometimes can be a problem with bone, tendon, bone grafts. And there would be no graft host reaction. That means that if you were to take the graft from somewhere else or from someone else, that there wouldn't be a potential graft host reaction. When you talk to the experts, though, there's still no clear consensus on really what's best. Bone tendon bone autograft still preferred by many for collision athletes. A study performed several years ago amongst NFL team physicians said that 85% of them would still use a bone tendon bone autograft for reconstruction of those high collision athletes. Other options are allografts, of which there's bone, patella tendon bone grafts, Achilles, tendo Achilles, and now newer grafts of quad tendons. So although patellar bone tendon bone has been considered the gold standard, what are the benefits of it? Well, it's your own tissue. There is fast bone to bone healing, and it's really strong. Faster return to play. In fact, this image on this particular slide shows Philip Rivers, who was quarterback when I was with the San Diego Chargers, who tore his ACL and had bone tendon bone reconstruction or autograft reconstruction, and actually made it back to official team activities in less than 5 months. And although that's not standard, nor would we usually recommend that, this is what this elite athlete was able to accomplish. So when we look at patella bone, tendon bone, what are the risks associated with that? Because as we started off, there's not a perfect graft. Well, when you actually take bone from the patella, you actually weaken it. So you actually create a potential stress riser or an area of patella fracture. Some people will report kneeling pain, meaning when you're kneeling down, you may have pain over the front of your knee. Weak quad mechanism, that means that your extensor mechanism or your quads are always going to be slightly weaker. There's studies that show that it may actually affect even one's 40 time or ability to sprint at the same pace that they did before. Loss of sensation, specifically from damage from the infrapatellar branch, and greater incidence of osteoarthritis is noted. Other options for grafts are hamstrings. Well, there's less pain associated with that with kneeling because we're not cutting something out of the front of one's knee. Lower incidence of osteoarthritis. Flexion contracture is something that is considered a potential risk. Weak knee flexion past 70 degrees and may elongate over time, but certainly there's some equivocal studies on that, but some of the things that have been identified. And here's just a few studies talking about the hamstring tendon grafts in some peer-reviewed journals. Quad tendon is something that has made its way back into the choice for autografts. Many years ago, it was looked at, and now it's really made a resurgence as a possible ideal graft. The issue is that it does make a sometimes prominent scar. Now, some of these can be harvested with arthroscopic or camera assistance, but it does leave a large scar, and there's a potential still with patella fracture if you actually take a piece of bone from the top of the patella. But there are some who are now taking the graft with no bone, and so that certainly would eliminate the risk of patella fracture. So when we talk about using allografts, you can use your own or you can use someone else's. So allografts, infection, rejection, those are things that are talked about. But I will tell you in practical terms, since I've been doing this over the last 15 years, that I have never seen anybody actually have a rejection or an infection from an allograft. And so I do think that that is certainly a concern whenever we're performing surgery. I don't know that it is necessarily unique to allografts. I think whenever someone is undergoing surgery, there's always a risk of that. Higher failure rate, well, I think that you have to certainly look at that in context. And I think when we look at allografts that were treated with high dose irradiation, greater than 2.5 megarads, that can weaken the graft. There's other chemicals that sometimes have been used in order to treat allografts, and that potentially can weaken them. And some may think that longer graft incorporation, so that it takes longer for the allograft or donor graft to heal within the bone sockets. And tunnel widening has also been reported, although I will tell you that is seen in all soft tissue grafts, whether it's an autograft hamstring or even a soft tissue quad. That is something that can occur. And this is just a quote of a study from the American Journal of Sports Medicine talking about the effects of irradiation on the strength of patella tendon allografts. So that's something that we are aware of, but in practicality, if you keep irradiation out of the picture and without chemical treatment or use fresh frozen allografts, the failure rate, as we were going to discuss, is actually very similar to autografts. So why is it so confusing to look at the allografts and determine whether or not they are a good choice or not? Well, it's because of many different studies. In some of the earlier studies, they didn't necessarily specify if the allograft or the donor tissue was treated with chemicals, if it was treated with irradiation. If it was treated with irradiation, sometimes it didn't necessarily state how much irradiation. And as we just talked about in the previous slide, it does matter. So how was the graft processed? Is it fresh frozen? Again, was it chemically treated? And the other thing is, how big is the graft? The other thing that one would always want to know is what's the activity level of the individual who received the graft. And we're going to talk about something called a Tegner score coming up. But that is something that helps us to determine how active is somebody when we're comparing the activity levels of certain athletes. Well, how do grafts heal? Well, a graft heals in 4 different phases. Initially, when we put any graft in it, it's going to go through graft necrosis. Then there's a phase of cellular repopulation, revascularization, and ultimately collagen remodeling. And you can see there it takes 1 to 2 weeks for the first 2 processes to occur. And then around 3 weeks, we begin to get revascularization and then collagen remodeling at about 4 weeks. And donor DNA completely replaces 4 weeks post-op in allografts, which means essentially your body is repopulating genetically the donor graft so that after 4 weeks, it is essentially yours. What I tell patients is that if you've ever seen lattice and then ivy growing on it, that's sort of what an allograft acts like, that essentially it resists early rehabilitation in order to get someone back on their feet, begin early range of motion, and then strengthening. And that over that time that the body essentially turns that graft into its own. As mentioned previously, it's important for us, if we're going to compare apples to apples, to know, are we talking about athletes that are performing at similar levels? Most of us would agree that a Pop Warner football player or an adolescent football player is probably at a different level than a pro NFL football player. And so a Tegner score sort of allows us to quantify how active is somebody. And then that's something that we can look at with respect to the failure rate of grafts when we're talking about failures in auto or allografts, and if someone is a very active individual or a more sedentary or someone that sort of sits around a lot. So this is essentially a tool that we can use in order to compare. And this is just a graph just showing, as I was just mentioning, from someone that's at a level 0, which is a disabled person that's inactive, essentially all the way up to a level 10 with a competitive professional athlete playing soccer, football, or rugby. And there's certainly, as mentioned previously, much confusion when you try to get on the internet these days, which I usually caution patients about, because unless you are a medical trained professional, it is very difficult in order to dissect the literature. And when you actually do look at many studies, you do see that the allograft rate, unless you consider some of the things we were talking about, may have a potential higher failure rate. And when we look at these athletes that are listed here, 50 consecutive young athletes, 5 professional with Achilles allografts 3 to 5 years out, no failures. So why is that people will still say that allografts have a higher failure rate? And why is it that some would say that allografts should not be used in high collision athletes? Well, I think as we talked about, you have to look specifically at some of the studies. And then also, I think technique, the skill of the surgeon, how many surgeries have they done? And that's important to consider as well. But when you do look at these 3 studies, you can see that if you do exclude irradiated chemically treated grafts, there's no difference in failure rate amongst allografts versus autografts. And in the bone patella tendon bone allograft, there's very small allograft sample, but older fixation method. So again, as talked about previously, you need to look at what information is reported in some of these studies. So do allografts really have a higher failure rate? Maybe. But I think other studies show 2 to 5 year results of ACL reconstruction using double tibialis anterior, that these were individuals that had high activity level. They were relatively young, 27 years of age, and they had a very low failure rate. And just like the most interesting man, when I use allografts, I do like to consider fresh frozen, non-irradiated. And allografts do have the advantage of no graft site morbidity, as we discussed. You're not having to rob Peter to pay Paul. Often less pain, smaller incisions, although I would be the first to say you certainly don't want to base the outcome of an operation on making smaller incisions. You want to do the right thing for the patient. Faster rehabilitation, questionable, although I will tell you clinically that's what I have seen. And some will use these routinely for revision surgery or when you're having to redo work where the graft has been taken, such as someone's used someone's hamstrings or if somebody has used their patella tendon before. The other thing that you should consider is the tissue bank. So if you are going to use donor tissue, making sure that it comes from a reputable tissue bank is important. And that's essentially what we're depicting here. And this is the official American Academy of Orthopedic Surgeons statement on allografts. The tissue should be acquired from facilities that demonstrate compliance, well-accepted banking methodology, and follow FDA good tissue practices. And the AOS urges all tissue banks to follow rigorous national guidelines and standards and recommends the use of tissue from banks that are accredited by the American Association of Tissue Banks. So that's something that you can certainly discuss with your surgeon. But one of the most basic questions when we talk about ACL reconstruction is, how strong does a graft need to be? And in this particular study, you can see that when we look at an Achilles tendon or the tibialis anterior, which is a favorite graft of mine, that is actually over twice as strong as the native ACL. So when we talk about what one is going to do after you reconstruct their knee, activities of daily living only requires about 450 newtons or 100 foot-pounds. Well, you can see that any of the grafts there that are listed are strong enough in order to withstand that. So when you put a graft or tissue into the knee, what happens? Well, the first 8 weeks is conversion of mechanical to biologic fixation. That means that it's sort of growing into the tunnels. We may use interference or different types of screws, bioabsorbable or inert material, metal screws, in order to fix the graft, extracortical or buttons, or transfix techniques. And so during those first 8 weeks, the fixation is the most likely place of where a graft may fail, and specifically on the femoral or the upper thigh bone side, the graft itself or the tibial fixation. So how do grafts fail? Well, initially, during the first 8 weeks, your graft is going to lose about 50% of its initial strength. The graft will undergo necrosis, as we talked about earlier, and that weakens it. And specifically, allografts have a higher persistent central necrosis, according to some. Failure of revascularization in order to revascularize, some feel that allografts have a higher incidence of failure to revascularize. Mechanical failure, such as the graft itself, non-anatomic, meaning that the surgeon may have placed the graft into a more vertical or too anterior position so that that may impinge on bony structures, causing it to fail. So in summary, fresh frozen non-irradiated allografts seem to have similar failure rates as autografts, as we discussed and showed in some of the peer-reviewed orthopedic journals. And you can't really differentiate between true failure and a re-tear in the literature. That's another concern. One of the most questions I get is that once I reconstruct an ACL, as if someone could actually tear it again. And of course, I'll say if someone does what would normally tear a normal ACL, you can certainly injure any graft. So use the graft and fixation system you can do the best job with. And this is what I always tell patients, to have that discussion with their prospective surgeon and ask them what they do most often, because the chances of having a successful outcome is dependent upon the number of times that surgeon has used that technique. When we talk about putting the graft in, the other thing to consider is making sure that it is in an anatomic position. That means placing the tunnels where they were originally. So just like in the great state of Texas, we are very familiar with oil wells, and especially out in West Texas, where there's lots of them in football, and unfortunately ACL injuries are very common. This is a good illustration. People understand now about horizontal drilling versus vertical drilling. Well, sometimes horizontal is better. And when it comes to ACL reconstruction, it is better with respect to drilling the femoral socket. For years, there was a consensus that the femoral tunnel would be drilled through the tibial tunnel. So if you didn't necessarily drill your tibial tunnel in the right position, then it would determine where your femoral tunnel would be. Most ACL surgeons these days, not all, and there's some great surgeons that still will do it the other way and in their hands achieve good results, but most will actually drill the femoral socket or tunnel separately than the tibia, and will drill a more horizontally oriented femoral socket. And when we look at a study that was done by my former partner in San Diego, who was part of the ACL study group, they actually did look at the position on the intercondylar notch and showed that there were no fibers at the 12 o'clock or vertical position on cadavers, and that the highest attachment was at 11 o'clock. And when you actually look at the footprint of the ACL and you look at the drilling techniques, that you could only reach the superior margin of the anatomic footprint in 2 and 4. Essentially, it means that if you were trying to do transtibial drilling, you could not get low enough on the notch in order to drill an anatomic tunnel. So when you look at MRIs or x-rays, what you can see, and this was again part of the study that my senior partner participated in, that as we'll show, this is a normal MRI and intact ACL on the far left, and then a reconstructed knee in the center using the anterior medial or more horizontal technique versus the transtibial on the far right. And essentially what we're depicting there is a more horizontal in the center picture and a more vertical on the right. And when you actually looked at the measurements and the angle for the reconstructed graft, looking at roughly an average of 56.9 in evaluator 1 that the anterior medial was about 57.5 versus 74.7. And essentially what we can see there is that the tunnels are more horizontal, and that when you drill transtibial, you create a more vertical graft. So when we looked at that particular group of patients, there were good clinical results in both groups that were done by very good surgeons who did a number of ACLs. And that's what I had said previously, that there's still many surgeons that will use the transtibial technique, but because they do a high volume, they certainly in their hands achieve fairly good results. But when we looked at what's called the KT manual max testing, there was a side-to-side difference of more translation, meaning more movement in the transtibial group than the anterior medial group. Essentially, that means that when the examiner checks the knee after reconstruction with one of these techniques, that the more horizontally drilled tunnels were more stable than the transtibial, more vertically oriented tunnels. And that becomes very true when we talk about rotational stability, that although the translation from front to back may be similar from looking at the two groups, when you look at rotational stability, because that anterior medial or more horizontally drilled tunnel and the orientation of it will allow for more stability in rotation. And the technique is depicted here. As you can see me doing an anterior medial technique, you have to really hyperflex the knee, so that's important, and making sure that you drill out the anterior lateral thigh, and you have to be very careful in doing this so that you don't drill out or injure the back wall of the femur. So let's talk about some actual cases now. Here is a patient that underwent a tibialis anterior allograft. 40-year-old male who was playing basketball, changed directions, felt the pop in the left knee. They had unstable knee with a +3 Lockman's. That's a test that we use in order to evaluate translation. They had a +3 effusion, a +3 pivot shift. And the graft choice was a non-irradiated, fresh frozen tibialis anterior allograft with extracortical femoral fixation and a tibial biocomposite interference screws with aperture fixation. And here, essentially, we can see this particular exam showing the translation of the Lockman's. And then we see the pivot shift maneuver with the shift here. And here we are just looking at a quick video inside the knee, looking at the damaged ACL, and there was some meniscus damage. And so here we are cleaning up the damaged meniscus with a shaver. We're cleaning up the remnants of the ACL. And then after this, we'll open up the notch so that we don't have mechanical impingement of the new graft. Here we are cleaning out the back of the wall so we can get all the way over the top, marking our anatomic positions on the femur and the tibia. Here we've drilled our tibial socket, and now we're placing our pin for our femoral socket. We drill this to usually a depth of about 25 millimeters. And then after this, you can see how low we are on the wall with this technique and cleaning out soft tissue debris. We then drill out through the femoral cortex, which usually in females may be around 30, 35 millimeters, in a male around 40 to 45 millimeters. And here's a nice picture of that femoral socket. Now we're pulling the graft up into the femoral socket. And once that graft is seated with this button on the outside of the femur, we will then fix it with a tibial screw on the other side, and it creates a nice stable construct. So with this, we are driving the screw up until it reaches into the joint. We then trim the suture here, and that creates a nice anatomic reconstructed ACL. So when we look at the post-op x-rays, you can see the button, and then you can see the screw here in this view, which is anterior, and that's usually where I like to put my grafts. Here's a second case where we've used a bone tendon bone in a 16-year-old male football player who injured his left knee, felt the pop. He had a similar exam as the other patient with instability and KT manual max of greater than 5 millimeters difference showing instability. This individual's growth plates had closed or was skeletally mature, as we would state. We elected for the bone tendon bone with shared decision making with the patient and used a biocomposite interference screw. Here's a graft table where we prepare the graft. This is where we harvest through a mini incision the patella tendon. This is us performing the operation with the picture of the arthroscope in the background. And this is what our incision looks like. Using the mini incision for harvesting, you can see that actually is quite small, about 2.5 centimeters in length. And here's our post-op x-ray showing our graft in good position. So in conclusion, my graft chosen fresh frozen non-irradiated tibial allograft or a patella tendon autograft in certain select collision athletes. Thank you for your attention, and I hope that this was helpful for you and informative with ACL reconstruction and graft choice. Thank you.